Now, I did want to talk a bit about pediatric imaging because we haven't got a lot of literature on it, but we do have, particularly in our areas which have higher community infection rates, we do have pediatric patients presenting with symptoms. So I'll go through the guidelines or consensus that has been published. Children tend to have milder clinical symptoms and also milder imaging findings. Lower rate of positive CT, but the ground glass opacity is the most common finding. The difference is bronchial wall thickening, which is uncommon in adults, is the second most common finding so far in the pediatric literature, which still remains pretty limited. We do have a consensus statement that's been put out by a team of radiologists from different countries to help provide some guidance in this period of uncertainty. And this has been published in Radiology Cardiothoracic Imaging about a week and a half ago. And their consensus or suggested approach is to say that the chest X-ray is appropriate if the patient's not responding to outpatient management, they're requiring hospitalization, or they're in hospital and you think they may have acquired their infection in hospital. They've also said that a negative chest X-ray cannot exclude pulmonary signs of COVID-19, particularly if you have a confirmed PCR test, and that a normal chest X-ray can't exclude it if you don't know the PCR result, but you still suspect it clinically. And they've also adopted a 4-category approach, which is similar to what we've adopted at ANSTA and RSNA and BSTI. And again, the reference for this is available at the final slide of the talk, which you're all welcome to have. So the pediatric consensus here really is typical, indeterminate, atypical, and negative. So we're talking the same language. Everyone is using the same classification, which will really help our clinicians. And we're talking again about the typical findings: bilateral, peripheral, ground glass opacity, or consolidation. It can be very difficult to determine on a chest X-ray if it's consolidation or if it's ground glass. And the suggested concluding statements, again, they're very similar, and it's really it's making me very happy that all of these consensus statements are saying the same kind of words. Indeterminate, so again, the ground glass or consolidation, which isn't typical in its distribution. Then the atypical findings, so single focus of consolidation, a pleural effusion, adenopathy, the central or the unilateral ground glass. These are all atypical and really should be considering another diagnosis. And then the negative result, it's normal. Think about what else it could be, with the caveat that it could still be COVID-19, particularly early on. They also considered pediatric CT use, and the comment that was made is that both the extent and the number of the abnormalities on CT tends to be reduced in children compared to adults. Common findings: the bilateral, peripheral, or subpleural ground glass or consolidation, and it's in a basal predominance. The halo sign was present more commonly in children, and that is focal consolidation with a rim of ground glass opacity. And this was present in up to 50% of cases early on. It then progresses to be ground glass opacity, and then it progresses to be consolidation. Crazy paving, so pleural effusion, adenopathy, these have not been reported commonly at all in the pediatric literature, but as more studies of the pediatric cases are published, we may find that this changes over time. So the consensus table here for pediatric CT, again, typical, indeterminate, atypical, and normal. And the findings again mirror the CT findings for the adults, with the exception here really of the halo sign being much more of a typical early feature than it is in adults. So we have a slide here from that publication, which goes through and shows 3 different phases in different patients. We have an early phase here. We have slightly more progressed phase here in the middle, and we have progressive consolidation here in a slightly more advanced case with severe shortness of breath. And the summary page from that article, which I actually found very interesting to read, they've come up with a series of suggestions, and they've said that if we use sequential chest x-rays, if clinically indicated, maybe all that we need to do rather than to move on to CT. If we need to do CT for clinical reasons, you should still do them, but just to be more aware of it if you're going to impact your clinical management. And they've also made the point that if you have a child who has only mild clinical symptoms, unless they develop worsening problems or they have pre-existing conditions that make them at high risk of progression, you don't need to image those people at all.